ready to go live.
Good afternoon, everybody. Welcome to the second ASPA FLEX webinar in the year of 2020. ASEAN Society of Pediatric Anesthesiology aims to educate as many people to be able to perform safe anesthesia for children. And this afternoon, we will have a very interesting topics on how to making pediatric neuro-anesthesia safer. Allow me to introduce myself. My name is Andi Ade. I am a pediatric anesthesia from Jakarta, Indonesia. I'm a member of ASPA Educational Committee. And today I was assigned to lead the ASPA FLEX webinar. And I will also introduce our moderator for and also do great work as IT support in the webinar, Dr. Fiba Fari Naik. Dr. Fiba Fari is the senior consultant anesthesiology from Department of Anesthesiology, Basavattarakam Indo-American Cancer Hospital and Research Institute in Hyderabad, India. She's also the executive committee member of ASPA and past treasurer Indian Association of Pediatric Anesthesiologists. She has a pediatric anesthesia fellowship, and she is interested in pediatric onco-anesthesia and vascular access. Today we will have 3 speakers. All will talk about the importance of safety in neuroanesthesia. And just to remind you about Q&A session. How can you ask questions or share your comments? You just send in your questions or comment via Q&A section, because the chat and raise hand function are disabled for this webinar. Our moderators will highlight your questions to the appropriate speakers during panel discussion. And some question will be answered directly by appropriate speakers in Q&A section. And for the certificate of attendance will be automatically generated and forwarded to those who submitted the post-webinar survey. And post-webinar survey will be forwarded tomorrow through your email. So be check your email. Please ensure that you have correctly keyed in your full name and email. Don't forget to visit us also in our website, our Facebook, and our YouTube channel after the webinar, because we will have the recorded version of this webinar. Okay, we have also polling during the session. So when a poll is launched, you will be prompted to answer the polling questions, and you will have like 30 seconds to respond and submit your answers. And we will share the results soon after we end the polls. After the result is shared, you may close the poll so that you can see the slide shared by our speakers. Okay, without any further, let me introduce you to our first speaker, Professor Dr. Girija Prasad Rat. Dr. Rat is the professor in Department of Neuroanesthesiology and Critical Care, Neuroscience Center in All India Institute of Medical Science, or AIIMS, in New Delhi, India. He is also a guide and examiner for DM in neuroanesthesia. He has more than 250 publications and more than 35 chapters of book. And he also editorial board member of more than 10 journals. He interested in pediatric neuroanesthesia and neuromonitoring. Please welcome Dr. Raj. The screen is yours.
So, Dr. Ade, Dr. Rat had poll questions to begin with, and I'm going to launch his first poll question. Please answer the question. The cerebral autoregulatory range in neonates is only at 40 to 60 millimeters of mercury mean arterial pressure, similar to adults at 50 to 150 millimeters of mercury, or of no clinical significance. I'm going to end the poll now. I see people still answering, so I'm just going to allow another 5 seconds. Okay, I'm ending the poll, and these are the results.
It seems the answer is 1, which is absolutely correct. And regarding its clinical significance, I will be talking in my talk. Means it will be discussed then and there only. So we can go ahead with the second poll.
Yeah, sure. Thank you, Dr. Rat. So the second poll question for Dr. Rat is this: which of the following pediatric neurosurgical condition may present with congestive heart failure? Brain tumor, meningomyelocele, vein of Galen malformation, and craniovertebral junction anomalies. I can see people answering still. I'm going to give another 5 to 6 seconds.
I think now they have stopped here.
Yeah.
And the answer is vein of Galen malformation. Although 50%, 55, 56% of audience poll is in favor of vein of Galen malformation, there are still certain doubts. But the answer is vein of Galen malformation, which again, I will address during my talk. Thank you.
Sure. Thank you, Dr. Rat. So we're going to move on to his talk.
Yeah.
Hello
Please, Dr.
everyone,
Raj.
and greetings from India. Before I start, I must thank the organizers of ASPA FLEX webinar series for this opportunity. I will be talking about essentials of pediatric neuroanesthesia. So this is the hospital where I am working at present. It is a high volume center where we operate more than 5,000 neurosurgical cases every year, and it includes the pediatric neurosurgical patients as well. And I don't have any disclosure for this presentation. So it's a broad topic. What I will be discussing here are the basics of pediatric neuroanesthesia and certain specific problems. However, I won't be discussing about craniosynostosis, which will be covered by the next speaker, and few more things. We all know children present with a set of inherent challenges, be it in the form of anatomy of airway, pulmonary physiology, anesthetic requirements. Moreover, there is a developing neurophysiologic status in these children apart from the neurosurgical disease process as well. So that makes this group of patients quite vulnerable. We also know the cerebral blood flow combines with cerebral metabolism quite well, and this cerebral metabolism is the cerebral metabolic rate of oxygen, and in both of them they increase proportionately with age, as you can see in this slide. Now, autoregulation. In neonates, the autoregulatory range is quite narrow. It is in between 20 to 60 millimeter of mercury, as you can see from this curve. It is in comparison to the adults, which is in between 50 to 150. So whenever there is a sudden change in blood pressure at the either end, that may result in cerebral ischemia or intraventricular hemorrhage. We also know about the Monro-Cayley doctrine, which has limitations in small children because there is open fontanelle and cranial sutures. That makes the intracranial space a bit compliant. So the mass effect of a space occupying lesion is usually masked with increasing in skull size. So whenever an infant comes to you with increased intracranial pressure, that means that the child is having an advanced pathology. Now, a little bit about associated systemic physiology. We know there are functionally immature organ system, be it kidney or liver. So there is decreased glomerular filtration rate and the concentrating ability in the children. Also, there is possibility of delayed metabolism of drugs. But what I must pinpoint here is cardiac output. 25% of the cardiac output is usually diverted to the brain. So whenever a child undergoes craniotomy procedures, there is high risk of hemodynamic instability because of blood loss. So in the preoperative period, when a child comes to you, a thorough neurologic examination should be carried out, and it should include, you will have to find out whether there is an acute increase in ICP in the form of altered sensorium or coma. There may be headache, irritability, and failure to feed. And these children, they might be vomiting, so there are possibilities of dehydration and electrolyte imbalances. Apart from all these things, one has to do a complete hemogram, coagulation profile, renal hepatic functions, and blood typing and cross matching, because there is possibility of significant blood loss and blood transfusion may be required. Premedication. Normally in neuroanesthesia practice, we avoid sedatives and narcotics because they will cause respiratory depression, increase hypercapnia, increase cerebral blood volume, hence increase in ICP. But if a child comes to the operating room crying and struggling, that will also cause increase in ICP. Then there is a different school of thought. Crying may actually lead to hyperventilation, and thereby it may cause decrease in ICP. But there are different scenarios as well, like in Moyamoya disease, crying may actually lead to transient ischemic attacks or stroke. In cases of vascular malformations, if the child struggles, there is possibilities of rupture. So we need to individualize the premedication. So if at all it is required, midazolam may be given in anxiolytic doses because that may not cause respiratory depression, or increase in ICP. Induction of anesthesia, the goal is to avoid ICP. So one must avoid hypoxia, hypercapnia, and possibly the use of volatile anesthetic agents. But then IV induction remains ideal. So there is also a possibility of needle prick before IV induction that may cause problems. That is why inhalation induction is carried out whenever there is no IV access. So sevoflurane in this context has replaced most of the anesthetic agents. So in our routine practice, we use hybrid technique, induce the children with sevoflurane followed by TIVA. Now maintenance of anesthesia, as a general thing, I must tell you that all the inhalational anesthetic agents are cerebral vasodilators, whereas IV anesthetic agents are cerebral vasoconstrictors. I just compared here in this table two commonly used anesthetic agents in neuroanesthesia, sevoflurane and propofol. Both of them, they cause decrease in metabolism and blood flow. But autoregulation is deranged in sevoflurane, whereas it is intact in propofol, and cerebral blood volume and ICP, they remain unchanged with sevoflurane, whereas it is decreased with propofol. Therefore, propofol should be the first choice in patients with increase in ICP, despite the fact that sevoflurane may be a good alternative as well. Monitoring, there are basic monitorings and special monitorings. So basic monitorings are used in all the pediatric neurosurgical cases. The special monitoring may be an arterial BP or CBP whenever a sitting craniotomy is carried out even in a child. Then it may help aspirating VAE, and precordial Doppler in those cases may be used. Also TE appropriate size if available may be used. And nowadays it is common practice to use IONM, intraoperative neurophysiologic monitoring. Fluid management, the target is to maintain normovolemia and hemodynamic stability. We know normal saline is mildly hyperosmolar, whereas ringer lactate is hypoosmolar. We must avoid glucose containing fluids, but there is then a concern of hypoglycemia in fasting infants. So in some of the patients, when the surgery is prolonged, we use 1 to 2% of dextrose in some of the children, but then surgical stress response also causes hyperglycemia, so it is better to avoid dextrose containing fluids. Temperature management, some reports suggest that the mild hypothermia may be beneficial, but there are complications with hypothermia as well. So the target is to maintain normothermia, whatever is available in the operating room, be it a warming cabinet to warm the fluids, or maybe warm air blankets, or any other measures as you can see in this picture. Patient positioning in children. So all sorts of positioning can be utilized. It may be a supine position for a supratentorial tumor surgery, or a VP-Sun surgery, or prone position for posterior fossa surgery, spine surgery, repair of myelomeningocele, encephalocele, etc., or a lateral position for ipsilateral posterior fossa tumors, or maybe a sitting position for a third ventricular tumor or a posterior fossa surgery. Now I will mention about sitting position in children. The main concern remains venous air embolism like in adults and its sequel. But that is the reason why this practice of sitting position, not only in pediatric patients but also in adults, it has been declined over the years. And the practice is also limited in some of the centers like ours in India. We still use it. The reason being, we carried out a study and found that the incidence of VAE and consequent hypotension was comparable in adults and children. Moreover, I and our colleagues, we carried out another retrospective study and found out that there is no difference in overall complication rates in different positions we used for these posterior fossa surgeries, be it sitting craniotomy or horizontal positions. Moreover, VAE is easily manageable, so the sitting craniotomy should not be contraindicated provided you have adequate monitoring, proper patient selection, and if you have an experienced team to handle these cases. Now recovery, the goal is rapid awakening. In few of our studies, we found that sevoflurane provides better recovery profile in children. So that may be the ideal thing, but then TIVA, if you are using, that also provides good recovery. Tracheal extubation, child should respond to verbal commands, and infant should open eyes before you go ahead with tracheal extubation. Some of the children may require elective ventilation, particularly in posterior surgery, whenever there is interference with cranial nerve nuclei or brainstem handling, and the brainstem function, thereby it may be involved. So these patients may have impaired airway reflexes, cough and gag reflex may be impaired, and there is impaired respiratory tract. So they may require elective postoperative ventilation. Now coming to the specific problems. First is hydrocephalus. These are all small children and infants. They present with increased head circumference, as you can see here in this child. And this is because of various reasons. They undergo usually CSF diversion procedures in the form of a ventriculoperitoneal shunt surgery, which is most common, or endoscopic third ventriculostomy. And some of these children may present with for revision of shunt because of malfunction of this ventriculoperitoneal shunt. These children are usually dehydrated, so they need to be rehydrated before induction. And there is possibility of gastric aspiration because increased ICP will cause gastric hypotonia, and sometimes the children must have taken a recent meal. So modified rapid sequence induction may be preferred. And because this child remains open during the ventriculoperitoneal shunt surgery, so heat conservation strategy, as we have discussed, should be followed. And during the tunneling phase of ventriculoperitoneal shunt surgery, there is possibility of increase in ICP. We used bolus doses of short-acting opioids, also increased the inhalational anesthetic concentration, and we found that that helps in maintaining the ICP at a proper level. And the neurosurgeon colleagues should avoid rapid drainage of CSF from the ventricular end once it is inserted, so that arrhythmia and hemodynamic disturbances during the intraoperative period can be avoided. Now coming to neural tube defects. These lesions occur because of failure of neural tube fusion during 4th week of gestation, and the defect may occur at various segments of spine and skull with herniation of meninges and neural tissue. So when it occurs in spine, it is known as meningocele or myelomeningocele. When it occurs in the cranium, it is known as cranial meningocele and encephalocele. Now coming to myelomeningocele, it is most common in lumbosacral region and may be associated with GR2 malformation and hydrocephalus. Normally these children, they undergo ventriculoperitoneal shunt surgery in supine position, followed by excision and repair of myelomeningocele in prone position. Some of the children may present with leaking myelomeningocele, which are real medical emergencies, and they may present with electrolyte imbalances. So how to do tracheal intubation in these children? In supine position, the swelling may be supported on a donut, or maybe in lateral decubitus position, which we routinely practice in our center. Now this is our experience of 135 such cases of myelomeningocele, and we found most of the children, they might be having associated with certain congenital abnormalities like hydrocephalus and GR2 malformation, as you can see in significant number of cases, also different comorbidities, and they are not free from complications. There may be intraoperative cardiac and respiratory complications in the form of tachycardia, bradycardia, etc., and bronchospasm, which is quite common, and it is around 15% cardiac events and 11% respiratory events in our series we observed. And some of these patients may present with venous air embolism, although they are operated in prone position. Now coming to encephalocele, and they may be anterior encephalocele, which may cause problems in mask ventilation, potential rise in ICP when the compression of sac occurs because of manipulation. So these procedures are carried out, means the excision procedure is carried out in supine position. And the other one is posterior encephalocele, which may present with difficult airway, and the intubation may be required in lateral position by placing the swelling on a donut, or placing the child's head beyond the edge of the table, or maybe sometimes we practice the needle decompression of the encephalocele sac that helps intubation in the children. So these procedures are carried out in prone position. Now we compiled data of around 118 patients. It's an old study, and we found that these children may have associated problems in 60% of patients, and 15% of these children presented with giant encephalocele, means the size of the lesion was bigger than the size of the head, and the most common site of presentation was occiput. And as you can see from this table, there were so many congenital anomalies associated in the children, and they also presented with hypothermia, hemodynamic disturbance, respiratory complications. So difficult airway is not the only concern. There are other postoperative complications like you see in this table that may occur in these children. Now Chiari malformation, they occur because of herniation of cerebellar components to the upper cervical spinal space. They may be of 4 types. The type 1 and type 2, usually they undergo surgery of posterior decompression with or without excision of tonsil, cerebellar tonsil. So sometimes suboccipital craniotomy is carried out. During intubation of these patients, there is possibility of bradycardia because of brainstem compression, and these children, they might be having strong vagal tone. And moreover, there is proximity to straight and transverse sinus. So there is possibility of massive blood loss and even venous air embolism. Now coming to epilepsy surgery, this may be broadly of 2 types: resection of epileptogenic foci, which is known as resection surgery, which may be excision of an lesion, maybe with awake craniotomy or under general anesthesia, or temporal lobectomy, which is otherwise known as anterior temporal lobectomy or amygdalo-hippocampectomy, or maybe a disconnection surgery where the interruption is carried out, cortical connection interruption is carried out to limit the seizure spread. So these are carried out in multilobar epilepsy. So there may be hemispherectomy, corpus callosotomy, and multiple subpial resections. Whatever may be the surgical procedure is, there are certain common anesthetic concerns like there may be perioperative seizures. These children might be taking anticonvulsants for a prolonged period of time. So they may induce rapid metabolism. So there is increased requirement of opioids, neuromuscular blocking agents, and there may be requirement of echo-guided resection of foci. So in those conditions, inhalation agents usually suppress these cortical responses. So opioid-based technique are used in these conditions, and sometimes to identify different areas of motor cortex, cortical stimulation is carried out under general anesthesia. So during that period of time, neuromuscular blocking agents will have to be stopped or antagonized, and if it is carried out in awake state, then that is known as awake craniotomy. And but then awake craniotomy is difficult to be carried out in children. However, it has been reported, it is quite commonly practiced in adolescents. However, it is very difficult to carried out in children less than 8 years as per the literature. That is the youngest age group that has been described. Now hemispherectomy may present with hemodynamic instabilities. They may require elective ventilation. And corpus callosotomy, they may present with lethargy and somnolence. So this type of procedures may require postoperative ventilation. Moreover, there is possibility of intraoperative blood loss in these surgical procedures. Temporal lobe epilepsy may undergo surgery under general anesthesia or even under awake craniotomy. Now I will mention few things about these brain tumors in children. We'll discuss at the end of the webinar in all details. These are all most common solid tumors of the children, and 2/3 of them, they arise from the infratemporal compartment, that is the posterior fossa, and they usually present with obstructive hydrocephalus, as you can see from this image. And during intubation, there are laryngoscopic responses, so ICP may be increased. Also during head pin fixation, there is possibility of increase in ICP. So all the measures available that has to be utilized during that period of time. There are position-related complications. There are cardiovascular complications because of brainstem manipulation and damage to the respiratory center and lower cranial nerve palsy that may present with apnea and airway obstruction, which is very common in post-epicurus surgeries. Now, vascular malformation. First, coming to the arteriovenous malformation. So this is the most common cause of subarachnoid hemorrhage in children, and the infants and children may present with hemorrhage, seizure, and hydrocephalus. Newborn may present with congestive heart failure because it is a very high flow state. Post-operatively, whether these children will undergo endovascular therapy or surgical excision, they may present with sudden hypertension and hyperemic cerebral edema. So they may be managed with labetalol, even sodium nitroprusside. Vein of Galen malformation, which is again a typical condition, as you can see from this image. They present with large AVM with high output congestive heart failure. Surgical excision is nearly impossible because they may lead to massive blood loss, even death on table. So I have never seen such a case, but they undergo embolization. One has to remember that these are neonates. They may present with congestive heart failure. Now, Moeller disease, these are all vaso-occlusive disorders of distal ICA. As you can see this angiography picture, there is occlusion in distal ICA. So there are collaterals formed in the distal part, which is in angiography known as puff of smoke appearance. And these children will present with transient ischemic attack, recurrent stroke, seizures, and headache. So these patients, they usually undergo revascularization procedures, and these revascularization procedures may be direct type like ST-MCA bypass. Mostly it is carried out in adults, also in younger children, but not in very small children. Indirect types, which is of different types that has been described: encephaloduro-arteriosynostosis, encephaloduro-arteriomyosynostosis. Likewise, there are various types that has been described. So the anesthetic goal in these cases include normovolemia and optimization of cerebral perfusion pressure. So preoperatively, the children, they are usually hydrated properly, around 1.5 times the normal hydration it is given in the children. And intraoperatively, the target is to maintain normotension, normothermia, normocapnia, and postoperatively, again, adequate hydration, adequate pain control, with multimodal techniques. It should also include scalp block, and one must target reducing hemodynamic fluctuations in the postoperative period, also hypo and hyperventilation due to emergence delirium and oversedation. Now I will discuss about the last issue, CV junction anomaly. These are all developmental disorders that affect the skeleton and enclosed neuroaxis in the CV junction, and there are concerns about the airway that has to be secured with minimal manipulation, and the surgery carried out is transoral odontodectomy. There is basilar invagination, as you can see here, which we can discuss later on. And so these patients, they undergo transoral odontodectomy and posterior fixation. During transoral odontodectomy, there is possibility of blood loss from the epidural venous plexus, and there are also possibilities of hemodynamic changes during posterior fixation, during prone position, where there is handling of tissues near the cervicomedullary junction. So these patients may require elective ventilation for 12 to 24 hours just to prevent complications of potential reintubation due to pharyngeal edema with a fixed cervical spine. So to summarize my talk, neuroanesthesia for children requires knowledge on cerebral pathophysiology, interaction of anesthetic agents on brain, and inherent problems of pediatric anesthesia. And the management will depend on specialized training in this regard. Thank you very much for your patience. Hello.
Thank you, Dr. Rath, for an excellent presentation. And I know that the topic was very vast, and actually the subtopics that you covered yourself could have been talks by themselves. But in the interest of time, we're going to move on, and we're going to move across the screen for the next talk, which is our neurosurgeon. And with pleasure, I introduce Dr. Wilson Ho, who is consultant neurosurgeon at the Hong Kong University Hospital, Hong Kong. And his interest is pediatric neurosurgery and vascular neurosurgery. And he's going to cover the topic neurosurgical concerns in children with craniosynostosis. So,
good afternoon. Thank you for giving me this opportunity to share with you our experience on craniosynostosis. My name is Wilson Ho. I'm a neurosurgeon at the Hong Kong Children's Hospital. I have nothing to disclose. Well, normally the skull growth is secondary to brain growth. At birth, the brain volume is around a quarter that of an adult, and then the skull is made up of bone plates joined together by sutures. The sutures and fontanelles allow the skull to deform during the birth process and allow skull growth as the brain increases in volume. So if a suture is fused prematurely, there won't be any bone growth perpendicular to that suture. In this diagram, the sagittal suture is fused. As the brain continues to grow, it can only expand the skull in the anterior and posterior direction, creating an elongated skull. Different types of sutures fusion will result in different types of skull deformities. The most common type being sagittal, followed by coronal and metopic. The lambda suture is least affected. The incidence of craniosynostosis in Western society is around 1 in 2,000 new births. In Asia, the incidence is lower. In Hong Kong, the incidence is around 1 in 7,000 new births. Craniosynostosis is a heterogeneous group of disease. In around 80% of the patients, only a single suture is affected. The other 20% affect multiple sutures and is often part of a congenital syndromes, such as ASPA syndromes, Crouzon, and Pfeiffer syndromes. Single suture craniosynostosis usually doesn't cause rises in intracranial pressure, except in severe cases. The indication for surgery is to correct the appearance of the head. Whereas when multiple sutures are affected, this will cause raised intracranial pressure and the patient suffers from developmental problem. The indication then for surgery is to release pressure on the brain and the eyes. Some patients may also require CSF diversion to treat the associated hydrocephalus. These patients often have other craniofacial and airway abnormalities that needed to be addressed as well. To correct the head shape in craniosynostosis, we need to cut away the fused suture and release adjacent bone to allow bone growth, brain growth to shape the skull. This can be done as an open procedure or with the help of an endoscope. Ideally, surgery should be performed under the age of 8 months. So after releasing the suture, we can take advantage of the fast-growing brain to reshape the skull. The open procedure is more suitable for bigger kids of around 6 to 8 months old. The surgical wound is a bit bigger and involves more dissection, thus more blood loss. The endoscopic approach, on the other hand, is suitable for younger patients. The wounds are smaller with less blood loss. But because of the smaller body size, the proportion of patients who require blood transfusions is similar to the open approach. Because of less degree of bone release, after an endoscopic surgery, patients need to wear a remodeling helmet for around 12 months. This is a patient suffering from sagittal craniosynostosis. You can see the elongated head shape, and there's a bony protrusions along the fused suture. After reflecting the scap, the fused suture is removed and cuts are placed on both sides. During the entire process, the dura is kept intact in order to protect the brain. Immediately after surgery, the head is already less elongated than pre-op. And 1 year later, the girl had a normal head shape and normal development. For endoscopic approach, incisions are made at the two ends of the fused suture, and then the endoscope is introduced to visualize the sections of the dura away from bone. The excised suture is then delivered through the wound. The patient is then put in a tailor-made helmet the week after the operations. The helmet works by allowing space for desirable area of the skull to expand while limiting other areas. The helmet is worn 23 hours a day for around a year. This shows the change in head shape from preoperative to 6 months and 12 months after endoscopic suturectomy and helmet therapy. Another 4-month-old boy suffering from premature fusion of the left lambdoid suture, he was put in a supine positions with the head turned right for endoscopic suturectomy. The dura was carefully dissected away from the fused suture, and the suture was removed under direct vision of the endoscope. Comparing the immediate post-op purple image and the green image after 1 year of helmet therapy, you could see that the parietal asymmetry has been corrected. Surgery for multi-suture craniosynostosis followed the same principle of suturectomy and making cuts to allow a more balanced expansion of the skull. However, every patient is different, and we need to work as a multidisciplinary team, including head and neck surgeons and ENT surgeons. A detailed preoperative planning is very important. Well, this is patients with ASPA syndromes, bicoronal craniosynostosis resulting in brachycephaly. The head is very short. Also, she has syndactyly that requires multiple hand surgeries to separate the fingers. On the right is another patient with Pfeiffer syndromes. After cranial remodeling surgery, he underwent distraction of the facial bone. Notice that he has also got a tracheostomy for airway protection. Another 2 examples of patients with multi-suture craniosynostosis, where all the fused sutures were excised to release the pressure on the brain. Let's look on the anesthetic side about positioning, eye protections, venous embolisms, and blood loss. The classical teaching for positioning is that for metopic and coronal sutures involvement will be in the supine positions, whereas for sagittal sutures and lambdoid sutures will be in the sphinx position. We don't like using the sphinx positions as it involves extending the neck, and the tracheal tube may shift during positioning. Furthermore, as the head is in the positions well above the heart, if a venous sinus is opened inadvertently, there is a risk of air embolism. We much prefer using the modified supine positions for sagittal craniosynostosis. We use an adult-sized Mayfield headrest to support the baby's neck. This allows the entire skull watch to be exposed. If there's risk of air embolisms, we can quickly put the patients in a transdeliver positions by lowering the head end of the operating table. For lambdoid sutures in endoscopic approach, we put the patient in a supine with the head turned to the opposite side. For open procedure, we prone the patient. With the head above the heart level, if a big vein or venous sinus is opened, air embolisms may occur. The skull bone also has a lot of venous channel, and the cut edges can also be a source of air embolism. To prevent air embolism, we can put the patient's head at the same level with the heart irrigate with copious amount of warm saline solutions. And also be very meticulous when dissecting the dura away from the bone and seal off any bleeding immediately with either cautery, hemostatic materials, or bone wax. Patients with craniosynostosis affecting multiple sutures, some of them also have facial hypoplasia with shallow orbits. As a result, many of them may have proptosis. So during positioning and during surgery, great care must be taken in order to avoid undue pressure on the eyes. Blood loss is a major concern for craniosynostosis surgery, with risk increasing during long surgeries, younger age, and also involvement of multiple sutures. From these photos, you can appreciate the extensive soft tissue dissection, creating a large raw area. So before skin incisions, we give the patients an IV dose of tranexamic acid and infiltrate the skin with 1 in 400,000 adrenaline solutions. Some centers, I know, they practice using erythropoietin 4 to 6 weeks before the operations in order to boost up the hemoglobin level, but we don't have any experience with that. We believe that meticulous hemostasis at each stage of the operations is most important. We believe in prevention of bleeding rather than transfusion. In our center, we always have 2 experienced pediatric neurosurgeons operating together. When dissecting the skin flap, one neurosurgeon used the monopolar cautery and the other surgeons stop every minute bleeding with the bipolar cautery. And by being very meticulous and obsessive, blood loss is minimized. And you can see that after the sections, the entire surgical field should be bloodless. During bone curing, we sometimes use the diamond burr instead of a cutting burr. Although this makes the process slower, but a diamond burr generates a lot of heat, which will stop bleeding from the bone. Also, any bleeding from the bone is immediately controlled with bone wax and Flow-Seal, which is a gelatin matrix mixed with thrombin. Another source of bleeding is from the superior sagittal sinus during excisions of the field suture. This is controlled by using hemostatic agents such as Surgisil or Tecosil. We looked at our data from our last 18 patients with single suture fusions. 15 were done openly and 3 endoscopic procedures. The mean age for open was about 8 months and 3.5 months for endoscopic procedures. The majority of patients were boys involving the sagittal sutures. The operative time for open procedure was longer than endoscopic procedure by around 1 hour. In both groups, around 60% of patients required blood transfusions. In the open group, the majority of the blood transfusions occurred in the post-operative period. Most patients with single suture surgery can be safely extubated at the end of the operations. Patients with complex syndromal craniosynostosis may have pre-existing facial or airway problems and needed to be considered individually. Because of extensive soft tissue dissections in open surgery, the wind drain output needed to be monitored very closely. Patients' hemoglobin may drop considerably in the early postoperative period due to either hemodilutions or high drain output and may need further transfusions in the postoperative period. To conclude, craniosynostosis is a premature fusion of 1 or more cranial sutures. This can be an isolated event or part of a congenital syndrome. The aim of surgery is to correct head shape or release pressure to the brain and eyes. Surgery can be done as an open procedure or endoscopic procedure aided by postoperative helmet remodeling. Anesthetic concerns include positioning, blood loss, air embolism, and post-op anemia. Thank you very much.
Thank you, Dr. Ho. I think Dr. Ho also have poll questions.
Yes. Right. Okay. So, what's the threshold for post-operative hemoglobin for blood transfusions in the patient that is 3 months of age?
We will wait for another like 10 seconds. Okay. What is your comment, Dr. Ho?
Okay. Well, so the majority of the response would be over a third would be in this range of 9 to 10 grams. Well, I think the practice for post-operative transfusions varies in different institutes and different situations. And I totally agree that 9 and 10 grams would be a threshold for blood transfusions, whereas for bigger kids, well, in centers for bigger kids that is over 6 months of age, we would take a lower threshold of 7 to 8 grams. Whereas for smaller kids, then I agree, we also use this threshold. Thank you, Dr. AD.
Thank you, Dr. Ho. Thank you for the very information talk, Dr. Ho. It is telling us about the techniques, how to increase the patient safety, and how important is the collaboration between team members in the surgery. And it is always good to hear the anesthesia consideration from the surgeon point of view. Okay, now let us move to our third speaker. Our third speaker is Dr. Maria Vanessa Christie. Dr. Maria Vanessa Christie is the member of Board of Directors from Philippine Society of Anesthesiology. And she is also the Quality and Safety and Compliance Champion Department of Anesthesiology, Makati Medical Center. She is the consultant of affiliated institution in Metro Manila. She is also the visiting consultant for Department of Allergy in Eastern Visayas Medical Center. She interest in neuro-anesthesia medical education, especially in residency training. Dr. Christie, do you have, I think you have a poll question also, right?
Yes, I do, Dr. Ade. So I just like to ask the audience, how often do you use dexmedetomidine for pediatric neuroanesthesia? Okay, I think 100% already answered, so I will end the poll right now. Okay, so 45% haven't tried using dexmedetomidine for pediatric neuroanesthesia, which is something that I actually expected. So I hope after this talk, maybe you'll start to consider
the number will increase. Yeah.
Well, hopefully, let's see. Okay,
Okay.
we can start the lecture. Thank you.
Okay.
Good day. I am Dr. Maria Vanessa Christie, a neuroanesthesiologist practicing in the Philippines. I would like to thank the organizers of the ASPA FLEX webinar series for allowing me this chance to speak to you today regarding dexmedetomidine for pediatric neuro. Before I begin, I would like to declare that I have no conflicts of interest. In the next 20 minutes, these are the things that I will talk to you about. We will do a little review on dexmedetomidine and then answer the questions why dexmedetomidine for the pediatric population and should we use dexmedetomidine for pediatric neuroanesthesia. My goal for today is to show you the most recent facts and evidences to help you as generalists and pediatric anesthesiologists arrive at a decision for dexmedetomidine's use. Dexmedetomidine, which I will be referring to as dexmed throughout this lecture, is the pharmacologically active dextrorotatory enantiomer of medetomidine. It is a member of the imidazole subclass and it exhibits high ratio of specificity for alpha-2 receptors. It has two known. Dexmed is approved and available for intravenous use in humans. It comes in concentrated and premixed forms and is usually used as a 4 microgram per ml preparation. Based on the manufacturer's recommendations, intravenous dosing is done either with a loading dose followed by an infusion or directly started as an infusion. Off-label administration has been reported and is widely done, mostly through the intranasal route using an intranasal mucosal atomizer, while others successfully administer dexmed through the oral transmucosal route, orally via nebulization, intramuscularly, and as an additive in regional techniques. Dexmed is a highly lipophilic drug, largely protein-bound, resulting in a large volume of distribution. It readily crosses the blood-brain barrier and penetrates extravascular sites. It is eliminated mainly through biotransformation by the liver, and inactive metabolites are excreted renally and fecally. It follows linear pharmacokinetics in adults with a clearance rate of 0.6 to 0.7 liters per minute and a half-life of 2 to 3 hours. It has a high inter-individual variability observed for clearance and distribution volumes, meaning cases like hypoalbuminemia and organ damage, changes in hemodynamics, and decreased cardiac output may all contribute to variability, especially in the ICU population. Unlike most sedatives and hypnotics, dexmed has no direct GABAergic effects. It acts on presynaptic alpha-2 receptors primarily in the locus coeruleus and peripheral postsynaptic alpha-2 receptors on vascular smooth muscles. Dexmed is most popularly known for its unique and clinical effect of mimicking natural sleep, or sedation and anxiolysis that is easily reversed with stimulation. This is mainly due to inhibition of norepinephrine release in the locus coeruleus. In the heart, the dominant action of alpha-2 agonist is a decrease in tachycardia through blocking of the cardioaccelerator nerve and bradycardia through a vagomimetic action. These can be profound after loading doses, but is usually self-limiting or can be resolved with anticholinergics. In the peripheral vasculature, there is a biphasic response to dexmed. Smooth muscle vasoconstriction during high plasma concentrations is accompanied by bradycardia and happens on initial loading dose, followed by a dose-dependent sympatholysis-mediated vasodilation once plasma concentrations decrease. Literature supports that these hemodynamic effects can be rescued pharmacologically or by decreasing the dose or duration of loading. Analgesia is thought to be through central spinal cord alpha-2 receptor inhibition, and shivering is thought to be inhibited through central activation of alpha-2 adrenergic receptors in the hypothalamic thermoregulatory centers. Diuresis, on the other hand, is thought to be through a central release of ADH and through peripheral mechanisms on the renal tubules and collecting ducts. Diuresis can be massive and can last up to 5 hours after stopping the infusion. This table lists the desirable effects of dexmed and compares them with other sedatives. Dexmed produces dose-dependent sedation that can decrease anesthetic maintenance requirements when used in a combined technique. It has analgesic effects and decreases opioid use. It can provide cooperative sedation and alleviation of anxiety. It maintains airway reflexes and has little or no respiratory depression, as well as facilitates ventilation and extubation. It decreases the incidence of emergence delirium and improves post-operative cognitive dysfunction. It suppresses central shivering and decreases post-operative nausea and vomiting. Recent studies have shown organ protective effects through pre-treatment with dexmed that are mainly due to the following mechanisms. Dexmed has anti-inflammatory properties by inhibiting central mechanisms that reduce catecholamines and cortisol, thus reducing cytokines and inflammatory pathways and improves immunity. Dexmed has been found to have antioxidant and anti-apoptotic functions by inhibition of phospholipase C and protein kinase C, which have a role in oxidative stress and apoptosis. Dexmed reduces hypercoagulation due to sepsis or ischemia-reperfusion injury by an antisympathetic effect on coagulation pathways. Dexmed has been shown in vitro and in vivo to improve blood flow and reduce erythrocyte aggregation. The following are the organs that Dexmed has been shown to protect via these mechanisms. Dosage and timing of doses are areas of studies for organ protective effects of Dexmed. Which brings us to the effects of Dexmed on the brain. Recent studies have shown that Dexmed can decrease cerebral metabolic rate of oxygen, therefore decreasing global oxidative metabolism, and it decreases cerebral blood flow, thereby maintaining neurovascular coupling. Vasomotor reactivity to carbon dioxide is preserved on Dexmed. However, effects of Dexmed on cerebral autoregulation have been inconsistent, with some studies saying that it impairs autoregulation while others say that it has minimal effects on the brain. Other roles of Dexmed in neuroanesthesia include providing controllable hemodynamics in the sense that it can be used for controlled hypotension, which can thereby improve your surgeon's operative fields, for example, during transsphenoidal surgeries. It facilitates awake craniotomy, intraoperative mapping, intraoperative neurophysiology monitoring, deep brain stimulation surgeries, and trauma surgeries. It is important to note that there have been reports that Dexmed affects motor evoked potentials, but not somatosensory evoked potentials during intraoperative neurophysiology monitoring, and that high doses of Dexmed for DBS surgery can affect microelectrode recording, especially in the subthalamic nuclei. For trauma surgeries, its role is in securing the airway via awake intubation for cases of spinal cord injury. Now we all know that the pediatric population is not just a group of small or tiny adults. However, Dexmed in pediatrics follows a similar pharmacokinetic profile as in adults, except for a decrease in clearance in neonates, which increases to reach adult levels by 1 year of age. Similarly, the effects and applications of Dexmed in pediatrics parallels that of adults. The most common applications of Dexmed in pediatric anesthesia are for preoperative anxiolysis, for non-operating room anesthesia, and for prevention of emergence agitation and post-op nausea and vomiting. Not stated here is the common use of Dexmed in the pediatric ICU. Now it's starting to sound like Dexmed is a panacea even in children, but there are some relative contraindications to its use as well as things to watch out for. Rapid boluses of Dexmed should be avoided in patients with high concentrations of volatile anesthetics because it can cause hemodynamic instability such as severe bradycardia in children with or without changes in mean arterial pressure. Dexmed should be used with caution in patients with cardiac conduction abnormalities because there have been reports of severe bradycardia and arrhythmias after Dexmed in such patients. Dexmed should be used with caution in patients with sepsis and septic shock because of the theoretical risk for hemodynamic instability due to sympatholysis. Presently, there are studies that have shown that Dexmed actually increases vasopressor responsiveness in septic patients. In the same manner, patients who are being treated with drugs that may predispose them to bradycardia and hypotension should warrant consideration prior to initiation of Dexmed due to the possibility of severe bradycardia or hypotension. There have been case reports of sinus arrest in patients after bolus doses in pediatric patients with drugs that increase vagal tone, such as digoxin. Patients with chronic hypertension have shown to have rebound hypertension after Dexmed infusion in the ICU. In patients with renal disease, there have been case reports of dramatic and alarming rise in blood pressure after loading or bolus doses of Dexmed. So caution should be used in patients with chronic hypertension. Patients with hepatic disease will most likely warrant a decrease in dosing as Dexmed is primarily metabolized in the liver. Other precautions to take with the use of Dexmed in pediatrics include reports on withdrawal symptoms after prolonged ICU use of Dexmed. Agitation and fever were the most common symptoms of withdrawal. Animal studies have also shown that Dexmed inhibits adipose and non-shivering thermogenesis via actions at the medulla, so this is something that must be considered when using Dexmed in neonates. External warming devices will be necessary when using Dexmed in this subset of patients. There have been reports of agitation and anger after bolus administration in children, as reported by the manufacturer, which cautions us with the use of bolus dosing in children. The same monograph also reported hypokalemia in pediatric patients after its use, but more recent studies have shown that the hypokalemia after dexmed use is actually consistent with hypokalemia due to the stress response of surgery, and more studies will be needed to verify this result. There is also a theoretical risk of adrenal insufficiency owing to the imidazole ring of dexmed. However, a recent small RCT on pediatric ICU patients showed that dexmed does not cause adrenal suppression and in fact can be used safely in patients with adrenal insufficiency. Diuresis has been explained earlier, and polyuria has been observed in patients with intraoperative dexmed use. Case reports have managed polyuria from dexmed by stopping the infusion and initiating vasopressin or desmopressin or by fluid replacement without any sequelae. To date, there are actually no absolute contraindications to the use of dexmed in the pediatric population, but these reports prove that knowledge of the drug and caution should be employed when using it. The clinical applications of dexmed in pediatric anesthesia are many, but what are the practical applications of dexmed in pediatric neuroanesthesia? Earlier, I have listed dexmed's role in adult neuroanesthesia, and it is the same in pediatric population. Dexmed has been mostly used in the ICU for sedation of intubated postoperative neurosurgical pediatric patients, for preoperative anxiolysis, for prevention of postoperative shivering and emergence agitation, and for sedation during imaging studies. Other notable uses of dexmed in pediatric neuroanesthesia in recent reports include the following. In the ICU, dexmed was used to manage paroxysmal sympathetic hyperactivity and traumatic brain injury in a pediatric patient. Dexmed has been widely used for awake craniotomies in pediatrics through the asleep, awake, asleep, or the sedation techniques either as a sole agent or combined with other anesthetics. This case series by Ard and colleagues is the first to describe successful use of dexmed in awake craniotomies for pediatrics. This actually mirrors adult studies which conclude that dexmed is safe and efficacious in awake craniotomies with less respiratory adverse events. Personally, I use dexmed as a combined sedation technique with propofol and fentanyl for awake craniotomies. Dexmed was also successfully used in multiple reports as the sole sedative for EEG studies in pediatric patients with minimal effects on EEG peak frequencies and amplitude. Several studies such as this by Anschel shows that motor and somatosensory evoked potentials are maintained during scoliosis and spine surgeries in pediatrics. Some studies have reported deterioration of motor evoked potentials at higher dosages of dexmed and should be kept in mind when using it for intraoperative neurophysiologic monitoring. In an RCT of 36 children, our dear Dr. Rath and colleagues have shown that dexmed resulted in a favorable recovery profile, demonstrating a lower incidence of postoperative pain and agitation scores, less postoperative nausea and vomiting, higher modified Aldrich scores on arrival at the recovery room, and faster to achieve full points for discharge in patients for spina bifida surgery. And to tie it all up, dexmed has been safely and successfully used in craniosynostosis surgeries, and this report actually highlights its value as an opioid-sparing agent in a pediatric patient for craniofacial surgery who was confirmed to be allergic to opioids and neuromuscular blocking agents after an aborted endoscopic strip craniectomy. Aside from the organ protective effects that I have mentioned earlier, the most exciting developments in experimental studies with dexmed are that animal models have found it to prefer neuroprotection in fetal and infant animals, and these are some of the articles. In light of present studies claiming that anesthetic neurotoxicity occurs in developing brains, dexmed seems to be a viable drug to include in our routine management of infants and neonates. So these studies, among others, have found dexmed to be safe and beneficial. Using adult doses, dexmed provided neuroprotection in infant rats and attenuated fetal neuronal injury induced by maternal propofol administration, providing neurocognitive protection to their offspring rats. So to put it in a neat little table, here are the summary of evidences on the advantages and disadvantages of using dexmed in the pediatric patient for neurosurgery. It offers anxiolysis and sedation without overt respiratory and circulatory inhibition. It reduces emergence agitation and cough, reduces post-operative nausea and vomiting, and decreases pain and opioid requirements. It does not significantly prolong PACU stay. It can improve cognitive function and decreases cerebral blood flow, cerebral metabolic rate of oxygen, and intracranial pressure. It decreases the stress response and inflammation. It allows early extubation in hemodynamically stable patients. It has shown to have organ protective effects, and it can also improve the surgical field by controlled hypotension. The disadvantages include the dose-dependent hemodynamic effects, withdrawal symptoms after prolonged ICU use. It has been found to interfere with non-shivering thermogenesis. Some patients exhibit anger and agitation after bolus administrations. It also has a questionable effect on adrenal suppression and hypokalemia, and it may cause polyuria. Now, after discussing the ideal and not so ideal effects of dexmed in pediatrics, specifically in pediatric neuroanesthesia, why did I have to devote one whole lecture for this drug? What is the controversy? The controversy lies in its approval for use. Dexmed is a relatively new drug. It was developed in the 1980s and received first approval from the US FDA in 1999 for sedation of mechanically ventilated patients in the ICU for 24 hours. In 2008, it received approval for sedation of non-intubated adults before or during surgical procedures. The EU followed shortly. So technically speaking, at least 50% of dexmed use is off-label. And this includes our use for pediatric anesthesia. So you might ask me, Dr. Christie, where does that leave us after having said that, right? Should we even use dexmed for pediatric neuroanesthesia? Well, after everything that I have presented to you today, my recommendations are the following. There are a lot of ways to making pediatric neuroanesthesia safe, and I believe the addition of dexmed in our arsenal of drugs is a move in that direction. So definitely, yes, we can use dexmed for pediatric neuroanesthesia. Dexmed is a drug with exciting applications and benefits, especially in the field of pediatric neuroanesthesiology. However, knowledge of how to use it and why to use it is important. Being mindful and vigilant of the possible side effects of dexmed and its management is necessary. The use of dexmed for pediatric neuroanesthesia is acceptable if the benefits of its use outweighs the risks. And when in doubt, don't use it. If you are going to use it, I would recommend using dexmed as a part of a combined technique, whether with other sedatives, opioids, or volatile anesthetics, and use it as a sole agent only when necessary. I would recommend using lower dose loading or longer loading if it is used as a sole agent in pediatric patients, or no loading if used in combination with other drugs. While dexmed will unlikely replace other anesthetics, its use as an adjuvant is what makes it a remarkable drug. It definitely has a place for use in pediatric neuroanesthesia. Dexmed's role is expanding, and hopefully we will see its approval for pediatric use soon. Before I end my lecture, here are the recommended dosing schedules for dexmed in pediatrics based on the most recent literature. You can take a screenshot for your reference. Intraoperative usage is titrated to effect or based on depth of anesthesia monitoring such as BIS or entropy. So to wrap it up, I hope I was able to show you that dexmed is an alpha-2 receptor agonist which has been shown to be safe for use in pediatric population and has applications in pediatric neuroanesthesiology. So thank you for your kind attention, and these are my references.
Thank you so much, Dr. Christie, for very well covering this topic. And it was a very elaborate description of dexmedetomidine and its use. As pediatric anesthesiologists, I'm sure most of us have used dexmedetomidine in some route, some form for some other indication, but as the poll showed, very few of us actually use it for neuroanesthesia. Thank you for opening this topic for us. And now I open the Q&A session. Dr. Ade, do you want to check the Q&A box and let us know if there are any questions unanswered?
Yes, Dr. Naik. We already have many questions from the audience. I would like to summarize some of them. And the first question is that So we will make it like a discussion, right? I don't want to like assign one questions to one speaker, but we will discuss the topics. So it will be like more for a discussion. So there is a question about what post-operative analgesia drugs that we can use for post-operative pain management, regardless the case. What do you think, Dr. Rath? I'll start from you.
Yeah, nowadays for post-neurosurgical patients, it is always multimodal analgesia. Multimodal analgesia means acetaminophen, paracetamol, that is what we give, IV paracetamol. Along with that, some other NSAID like ketorolac tromethamine injection, that is also given. And apart from all this medication, scalp block. This has been routinely nowadays practiced, particularly patients with Moya disease. We have started routinely giving scalp block, regional scalp block. That helps these patients. And other than that, if the child is in adolescent age group, if the child can understand things, then patient controlled analgesia with even opioids, that will also do, provided these are spine cases, not intracranial procedures. So intracranial procedures, we hardly use opioids, but agent when it is required in some of the cases, low doses of fentanyl, sometimes we also use in the post-operative period.
Dr. Christie, regarding the use of dexmedetomidine, can we also use it like for post-operative pain management, like as an adjuvant, or what do you think?
Yes, actually, there have been studies that show that dexmedetomidine can be used as an adjuvant for pain control for post-operative neurosurgical patients. However, I think there are a few studies that say that there is no difference in terms of as needed morphine or opioid requests from the patients with or without dexmedetomidine. So I think more studies have to be done in the pediatric population for this. But I would agree with Dr. Rath. Scalp block is actually a very important mode for post-operative pain control in the pediatric patients, along with acetaminophen and ibuprofen is actually what we use here in our country.
Dr. Christie, I see a couple of comments on the sedative effects of dexmedetomidine. Does the sedation get prolonged, or is it difficulty in waking up these kids? What's your experience?
Thank you. Actually, they did a RCT for pediatric day ambulatory surgeries for with dexmedetomidine, and they did actually find a significant increase in PACU stay. But then they said it's not clinically significant, because if you go through several articles, they would say it's about 10 to 20 minutes increase in stay in the recovery room. So though it's significantly, statistically significant, it is not clinically significant. So I think it won't be such a concern.
So can I add one point on dexmedetomidine use in pediatric patients here?
Yeah, please, Dr. Rath.
Yes,
Yeah.
yes, please.
So thank you. So routinely we don't use in pediatric patients, but for research purposes in small children, we are using it. But some of our colleagues, they are using it in other cases as well. But I have done 3-4 cases of AVEC, pediatric AVEC craniotomy. So in those cases, I used dexmedetomidine as a sole anesthetic agent, and it works wonderfully, provided the child cooperates with you. So in all the 3-4 cases I did, it was quite successful. And I had to give small boluses of fentanyl in between, depending on the scenario. And of course, scalp block.
Do you have any opinion, Dr. Ho?
Well, we routinely, along the wound edge, just before waking the patient up, we routinely instill local anesthetics just to cover the early postoperative period. And usually, usually paracetamol works pretty okay. Yeah.
Okay. Okay, Dr. Naik, do you have any other comment for this?
So I see a question here regarding the intraoperative fluids. So we'll start with Dr. Rath. So what you already mentioned about the dextrose containing fluids and the fact that it may not really be required. So could you just elaborate slightly more on that? What fluid do you use and how much do you use?
Yeah, it is the same protocol, means there is no specific thing that which fluid has to be used. Nowadays, we are using plasma light, but any of the fluid you can use. When we didn't have plasma light, we alternatively using ringer lactate and normal saline as well. So there is no hard and fast rule that which fluid has to be used. Everything has its own indications and contraindications and problems. So that is how we are using.
Sure. So basically a balanced salt solution, whatever is available for you. And as you mentioned that if you need to add glucose, it can be done for very small children, but only after checking the blood glucose levels.
Yeah, I mentioned one thing there that 1 to 2% dextrose sometimes in prolonged surgeries, we add to the children. That helps. And at the same time, we monitor the sugar level.
Sure, thank you. Dr. Ade, there's a question on desflurane. So
yeah, regarding the anesthesia technique for induction, what are you prefer? I mean, of course, if they don't have IV, then we should do inhalation. However, what is the best choice for that? Dr.
I will take up that question. Should I? Yeah, obviously, sevoflurane should be used as an induction agent for obvious reasons, because desflurane is somehow it cannot be tolerated by the child. But for maintenance, we carried out a couple of studies as well, and just to look for the recovery. And it was almost comparable. Clinically, they were comparable. In statistically, maybe there is some differences. At 2 to 3 minutes of difference statistically, it doesn't make any sense clinically. So the outcome was, the recovery outcome was better in both the groups. But then obviously sevoflurane remains the choice because it is smooth. It is smooth to be induced as well. But desflurane can be used, and like there are several indications for desflurane. At least theoretically, they suggest literature-wise that it works well for obesity, and the recovery is good. So in spine cases, most of the, based on the choice of our colleagues, they are using desflurane routinely in neurosurgical cases, even in tumor cases. Initially, whatever the impression was, it causes increase in ICP. That is no longer there. It is not important what agent you are using, how you are using it is important.
Okay.
Yeah, thank you. But I just wanted to emphasize that desflurane should be used only after IV induction. So like sevoflurane can be used for inhalational, please do not use desflurane for inhalational induction.
Yes.
Yeah, it's for maintenance. Okay. What is the hemoglobin threshold that usually we agree before the surgery?
What does a neurosurgeon think? I think there could be a controversy there.
Well, before the operations, we don't have a specific level that we would not operate, just a normal level. Well, we haven't had a chance to try erythropoietin in order to boost up the hemoglobin level, but this is something that we definitely look into it and see if this helps.
So can I add something here?
Please, please.
Because Dr.
Please.
Bo talked about craniosynostosis. I did one case where the hemoglobin was 9, but I had to accept the case based on Indian scenario. But I had to start blood from the beginning. So it was a case of frontoorbital advancement. and there was too much blood loss. So normally what I would prepare is the hemoglobin should be at least more than 10.
Yeah,
Yes, I
yeah,
would also agree with Dr. Rack there. No, I guess it depends on the urgency of the procedure. If it's an emergency procedure, then there is no minimum hemoglobin level that we will wait for before we proceed. But if it's an elective procedure, I would agree with Dr. Rack that 10 is the minimum.
But then I would say that it also depends on the type of procedure. I mean, if it's a VP shunt or something simple where we wouldn't expect blood loss, probably 8 hemoglobin is something that is accepted in my institute, where we expect minimal blood loss. We could probably go ahead, knowing the scenario in Indian population that the hemoglobins can sometimes be really low in these children.
Yes.
Talking about Dr. Ho's question, that pool question, he asked about what should be the hemoglobin. I could not understand how much they target, but I would prefer to keep it, not to allow it less than 8, because there is possibilities of oozing in the post-operative period. So I will prefer to have the hemoglobin level around 10 only. I don't want to the hemoglobin to drop down to less than that. How do you manage those patients, Dr. Ho? I would like to hear from the. I could not hear properly.
Sure.
I'm sorry.
Okay, right. For our patients, that are over about 6 months of age, we take a slightly lower hemoglobin level before we consider transfusions to about 7 or 8, and unless the patient is symptomatic. If the patient is asymptomatic, we take down to 7. But the pediatrician is always telling us that this is a bit too low, and we should start considering transfusion earlier. Well, as surgeons, surgeons are trying to, we're trying to prove that we can do it without transfusions, but it's not always the right thing to do. I totally agree. Given that transfusions, the risk of transfusions isn't that high.
Okay.
Yeah. And the age of the child, like in children, if they are less than 3 months, probably we need to keep higher hemoglobins, like Dr. Rath just mentioned.
Agree, totally agree.
Yeah, agree. And do we have like a specific blood conserving strategy for this kind of patient? I mean, for craniosynostosis, for instance?
Well, we believe meticulous hemostasis is the most important part. Try to prevent blood loss rather than replacing blood loss. For the child this young, cell saver would not be an option because you need a lot of blood to prime the machines, and that so cell saver is out. So in our institutions, what we do is we always have 2 experienced pediatric neurosurgeons operating together, and one of us would be responsible for cutting, and the other one will be solely responsible for hemostasis, be it at the stage of skin cutting or at the stage of bone drilling. So for every minute bleeding, we'll stop immediately, and we won't proceed until the field is entirely cleared of any bleeding whatsoever. And also the same goes for bone cutting as well. And by doing that, very often we could prevent intraoperative blood transfusion.
Yeah. Dr. Christie, do you think that using dexmedetomidine can have correlation with the blood bleeding in the perioperative?
Yes, I mentioned earlier in my slides that dexmedetomidine has been successfully used for controlled hypotension. So there have been some studies on orthognathic surgeries, so by ENT surgeries, and they've actually shown that it has decreased blood loss significantly. And this is also one reason why some specialists opt to use dexmedetomidine for neurosurgeries, such as I said, in transsphenoidal surgeries, to make the blood loss, to control the hypotension and avoid bleeding in the surgical field.
Just one last question, I think we are nearing the time for closure, is on ketamine. There seems to be some controversy regarding ketamine, whether it increases the intracranial pressure. Is it okay to use ketamine? So I'm going to start with Dr. Christie first. What do you think, Dr. Christie?
So I think the controversy there lies from a study in 1970s. It's historical that they did that showed increases in ICP when they used ketamine in spontaneously ventilating animals and then patients eventually, of course. But this has already been debunked. So ketamine used in mechanically ventilated patients or well ventilating patients can actually decrease ICP or maintain ICP. So yes, you can actually use ketamine for neuroanesthesia and pediatric neuroanesthesia. How about Dr. Rath?
Yeah, I agree with you. Means the same thing here. Only one addition that it is a NMDA receptor antagonist. So that way it is a neuroprotective agent. So that is why nowadays more and more people, they are using ketamine for various purposes. For example, in status epilepticus, it has been used as a rescue sort of drug when midazolam propofol doesn't work. So at higher doses of ketamine, it is being utilized. So similarly, there are multiple things like routinely some of the centers in the West as well, they are using ketamine, for example, in spine procedures. So nowadays, there is no more constraint with regard to ketamine. Yes, there are certain constraints with regard to intracranial procedures where other drugs are available. Obviously, its utility is limited.
Now, I'd just like to address this other question. What about low-dose ketamine use for post-operative analgesia as a part of a multimodal analgesia regimen? Yes, you can use this even for post-operative neurosurgical patients. However, scalp block, acetaminophen, and ibuprofen actually most of the time covers pain from neurosurgery.
Dr.
But you may use
to know
ketamine.
about a combination called keto-dex. Any experience?
Yes. Personally, I don't use it. Actually, I read about it from Indian counterparts. So yeah, not personally, but I can see the value of using it, and I think it will actually really work.
Okay, we don't have that in Indonesia also, I think. Okay, considering the time, I should wrap up the discussion. Thank you very much for all the speakers, Dr. Rath, Dr. Ho, Dr. Christy, and our moderators, Dr. Naik, and also our partner from this, Dr. Teddy Fabiola from Singapore. Thank you very much, everyone, and we will meet again with you next month in another topics of ASPA FLEX. Please don't forget to register and join the ASPA FLEX. Thank you again, everyone. This is a very wonderful and enlightening afternoon for us. So then we hope we can do much better in our neuro-anesthesia pediatric patient. Thank you very much.
Thank you.
Thank you. Bye-bye.
Thank you very much. Bye.